Mary Gingrass. I practice in Nashville, Tennessee. I did my residency here from 92 to 94 with general surgery before that. And I'm thrilled to be back. I apologize for being late. So I kind of fell into being talking all around the world about liposuction, which is kind of funny how the wind blows sometimes. And I was recently asked to kind of give my personal evolution of, how'd you get there and how did it all end up 30 years later? Because I've been in practice now 30 years. So the backstory is that, again, I did my residency here, plastics from 92 to 94. And this is a picture of me and my partner, Mindy Hawes, and the great Bubba. I'm glad to be here with you. When I finished my plastics residency, I went down to Nashville, Tennessee to do a fellowship, and it was basically in breast aesthetic and reconstructive breast surgery. There was kind of an emphasis on aesthetics in addition, but mainly I went down there to learn about breast recon. In January of 1995, Maxwell invited Michael Zocchi, who is an Italian plastic surgeon, who had been on the trail giving talks about ultrasonic liposuction, and it had been in use for a little while, but it hadn't really been popularized in the United States yet. And Zocchi and Michael Zocchi and Pat Maxwell were friends. Zocchi had actually given Maxwell a machine years earlier, and as cavalier as Maxwell is, he waited until Zocchi came and taught us how to do it, because it is a potentially powerful device. So just backtracking a little bit of brief history of liposuction before that the ultrasound sort of hit the United States. Obviously, Allouze and Fournier introduced liposuction, popularized it in France in the 1970s. It was initially a very just blunt cannulas, negative pressure, dry technique. It was pretty bloody, but in contrast to the curettes that had been being used with not very good results, they were showing some good results, and it definitely caught people's attention. And this is from a 1983 article in PRS. And so people started paying attention all over the world, including the United States. So UAL wasn't anything new when it hit the United States. It had been being done in Europe, Middle East, particularly Israel, South America, mostly Brazil. Zocchi had even published in some American periodicals. And just a couple other little backstory things. 88 was when, embarrassingly, dermatologists developed what became known as the Klein technique and really popularized a little bit safer liposuction with the wet techniques. He studied it very nicely in 1990, came out with what became known as the Klein formula, and good research showing that you could inject as much as 35 milligrams per kilogram of lidocaine and safely perform liposuction on an outpatient or inpatient basis. And this was originally developed so that the dermatologists could do liposuction larger and larger volumes in an outpatient basis, whereas the plastic surgeons were, for the most part, doing it under general anesthesia. So also just a little backstory on fat injection, which is kind of interesting because it's become so widely used now. All of us use it, almost every day, weekly, whatever. It really had a very slow startup, and fat injection was used all the way back to the original liposuction clinical trials, but it was met with a fair amount of skepticism. Sidney Coleman, who you may sometimes get called kind of the father of fat injection, started presenting at an ASAPS meeting in 1988, leading up to his Coleman technique, which he published, and people were getting more and more interested in fat injection. It was safer, but again, a lot of this was still being done in the face. And interestingly, back in 1987, then called ASPRS, was they issued a moratorium and really sent a lot of signals out. Don't do fat injection, it's not safe, especially in the breast. We don't know what it does. We don't know if it interferes with mammography. We don't know what obviously there's going to be some fat necrosis. Are we going to be able to tell the difference between fat necrosis and cancer? And they really issued a pretty strong signal or moratorium on fat injection. So there's always been kind of controversy around liposuction. So what is ultrasonic liposuction? I talked to Nicole, Dr. Summer, this morning, and she said that you aren't even using it here anymore. But ultrasonic liposuction is it's equipment that you use. It's a piezoelectric crystal in a handpiece that converts electrical energy from the wall into a mechanical energy, which is transmitted down a probe or later a cannula. And this titanium probe then fragments the fat cells, creating like a fatty emulsion, which then can be sucked out with negative pressure. So the advantages are that because the ultrasonic frequency just vibrates and lyses the fat cell membrane, but not the vasculature, it doesn't injure the vasculature as much, then there's less vascular trauma, less bleeding, better recovery, less tissue trauma. And that was sort of hard to prove, but there certainly is less surgeon fatigue, and as larger and larger volumes were being done, it was a big advantage to not be in a cold, hot sweat when you're done with a large volume case. So it is physically easier, as you now know the power-assisted liposuction is as well. The thing that really caught both positive and negative attention was the fact that especially Zoki and the early proponents were advocating that there's better skin retraction with ultrasonic liposuction. And the reason for that was that you could give controlled injury to the undersurface of the skin or to the dermal elements and cause better retraction. But you can also, with any tool, there also comes risk, and you can injure the undersurface of the skin or microvasculature as well. So the disadvantages then translate to this potential for thermal injury. If it's done properly, there is not thermal injury, which we did studies to show, but if performed incorrectly, especially in a dry environment or without proper technique, it can cause thermal injury. It does require a little bit larger incisions, and it definitely added to procedure time early on, because the original probes you couldn't evacuate at the same time. You applied the ultrasonic energy, fragmenting the fat, making the emulsion subcutaneously, and then you had to go back as a second step and suction out the fatty emulsion. So these are just, this is an article, I think Tazi or Shefflin published this in 1996, and they were showing really, really aggressive stimulation of the undersurface of the skin. And they were honest people. They also were showing that, yeah, you can burn the skin with this too. So what this kind of caught everyone's attention here in the United States, because we're always worried about legal implications and, of course, patient safety, and they wanted to roll it out in a safe fashion. So this is just kind of some of the original machines, not super important. So how did things roll out? In 1995, Zoki comes to the United States. Shortly thereafter, in March, an ultrasonic liposuction task force was put together. It had people representatives from ASAPS, ASERV, ASPS, we're now called ASPS, Liposuction Society in North America, PSCF, and a lot of smart people got together and tried to decide, how are we going to educate people, how are we going to make sure nobody gets hurt, and these are just some of the people on that early task force. So in March of 1996, we had a symposium in Nashville, and all the kind of powers that be, after a lot of sort of infighting and decision-making, came to Nashville. Everybody was given instruction on how to perform the technique. It was decided who was going to do the courses, and the cadaver courses were developed out of that meeting. So the cadaver courses were given before and after meetings, to try to make it convenient for people to go. And the threat was that if you didn't take a course, you couldn't get malpractice coverage for ultrasonic liposuction. So people were taking the courses. In late '96, I helped Jack Fisher present or operate at Baker Gordon, and I also had the pleasure of coming here, and I was a visiting professor in 1996 at SIU. So a flurry of publications came out after that. We published our first 250 cases. We did tissue temperatures, documented that proper technique, you weren't necessarily causing injury to the skin or undersurface of the skin, or causing potential for necrosis. Rod Rourke published a book. They documented no significant difference in sensory changes. But as usual, there's controversy. The anti-UAL was largely led by Peter Fedor, who came out and said with this technique, you can't tell the difference between regular liposuction and my liposuction, and went on to develop another machine. So there also were accusations of free radical, which didn't really amount to anything. So anyway, teaching courses then began. I was going kind of all over the country. The things that were catching people's attention were treatment of gynecomastia, which was very frustrating with traditional liposuction. Remember, there's no power-assisted liposuction yet. And it was physically difficult to get the breast tissue out, and we were showing improved results and less trauma and hematoma for gynecomastia. Sorry. Some of the areas that were previously considered kind of taboo were arms, anterior thighs. Both of those areas we were showing, I think, improved contour and better recovery with less contour deformity with the ultrasonic liposuction, because it really kind of acts almost like there's a feathering effect at the end of the cannula that's a little bit more, I like to think of it as more offensively treating the tissue than defensively just pulling out tissue. Circumferential thighs and large volume also was an early advantage, and of course combined techniques, which interestingly was still kind of controversial to do liposuction and tummy tucks at the same time, or excisional procedures. So what's changed since then? All those original courses I did with slides, dual projection. You carried your slides with you on the plane. This is what you put in your overhead compartment. And now we have, of course, PowerPoint video, which is so amazing for education. Superficial liposuction was also very much kind of a no-no early on, and it's developed into like pretty amazing results with high-definition liposuction. Now, fat grafting, of course, we know has changed how we do so many procedures in reconstruction and cosmetic surgery. Around 2000, the power-assisted liposuction machines were starting to be developed, and Vaser was another purportedly more pure ultrasonic liposuction machine. It only has a probe. It doesn't have a cannula, meaning you can't suction at the same time. But admittedly, the vibration at the tip is definitely more pure when there's not a hole in the probe. So, and that Vaser is the one that stood the test of time, and it is still available now. The big thing that's really changed and kind of put ultrasonic liposuction for many in the rearview mirror is that the safe liposuction techniques developed by Simeon Wall and popularized by Simeon Wall. He originally was using ultrasonic liposuction, but as the power-assisted liposuction became perfected, he exclusively uses power-assisted liposuction for. And any residents who aren't familiar with this, it's a great technique, and I would strongly recommend learning about it if you haven't. So it's separation, aspiration, and fat equalization, and we can talk more about it. I don't know, what's my time period here? Also, expansion, vibration lipofilling is taking the same power-assisted device, flipping around the tubing, and actually injecting the fat with vibration and power assistance and vibration. So it can really speed up, and some say do more safely inject large volumes of fat. And again, there's people showing really nice results with all of these. So just the power-assisted liposuction and Vaser kind of hit the track in early 2000. Fat injection is finally gaining some speed. It wasn't until 2009 that ASPS, then ASPS, lifted their moratorium. There were good studies documenting that you could tell fat injection from microcalcifications, and this was largely kind of spearheaded by Scott Speer, who started publishing on fat injection in the reconstructed breast. And then some other kind of interesting things that happened were Roger Corey, right up the road in St. Louis, had developed the Brava system where you pre-expanded the tissue and were showing better fat take. Hoyos is sort of the father of high-definition liposuction, which I don't think is still mainstream. It's very aggressive. It's also a very aggressive cosmetic result. But Alfredo Hoyos has really nicely made this popular and shows pretty amazing results. He just recently published a study kind of documenting his evolution, originally using traditional liposuction, then morphing into ultrasonic liposuction. He still uses ultrasonic liposuction, and many do for the high def, but also 4D is considered etching, et cetera, superficial, but injecting as well. So that's changed a lot since. The safe lipo technique was kind of getting to be mainstream in about the mid-2015, 2016. Simeon initially was using the basket cannula on the power-assisted liposuction. The basket cannula is like the exploded tip, not with any suction, but originally his concept was using ultrasonic liposuction to sort of jiggle things up and like a jackhammer technique with ultrasonic liposuction. And then as power-assisted liposuction got better, he switched over to doing that early separation of the fatty tissue with a basket cannula, not sucking, just treating the subcutaneous fat first with a separation technique. And that eventually became safe lipo. Del Vecchio popularized the expansion vibration where you turn the tubing around and inject with the power assistance. I think the history just needs a little bit of time spent on BBL, because I would say Mendieta was the first person to kind of popularize and talk about gluteal fat grafting, was showing some great results, but there were more and more complications, and it was getting hard to ignore the problems that were happening. The BBL alarm, so to speak, went off in about 2015. And again, the powers that be created a task force, and we're getting a little more efficient with this now, but within 2 years, they came out with some recommendations to make gluteal fat grafting a much safer technique, mostly documenting that it was absolutely imperative to stay in the subcutaneous plane rather than muscle injection, which was definitely early on. It was mostly being injected into the muscle, and that was because of high pressure finding its way into the lungs. So the plastic surgery, or the ASERF, funded a number of studies, which I think we should give ourselves credit for figuring out what was wrong, why is it happening, and how do we fix it. And I think that was definitely a success. This is just sort of showing through the lens of Baker-Gordon different techniques that were being shown with live surgery over time. So my personal experience is, again, I was definitely there for the early part of the UAL rollout. By mid-2000s, I kind of stepped out of the boxing ring. I had three projects to work on. These are the fruits of that labor. And somewhere over that time period, my practice kind of morphed from not really that much liposuction at all, and I'm doing almost all aesthetic breast surgery now. So I still use UAL. I still do, obviously, some body contouring. I have a purely cosmetic practice at this point. I still prefer I have access to UAL. I have access to power assistance. When I first started kind of noticing or thinking about why do I use what, was one of my surgery centers. I operate at hospital-based surgery centers. One of them only had PAL, and the other one only had UAL. So I found myself sort of scheduling cases specifically around what equipment that I wanted. And I still prefer to do gynecomastia with UAL. I still prefer to do arms and anterior thighs with UAL. I really feel like I get a smoother, more predictable, less traumatic, and secondary liposuction. Why for secondary liposuction? I think there are cannulas and probes now that you can adjust exactly what kind of energy you want to apply to the tissue, and you can be pretty disruptive. You can almost remove breast parenchyma with higher energies, a little bit more risk of thermal energy, but a lot of tools to do different things. In the interest of time, I'll move on. I prefer PAL. I tend to do the larger volume cases with the power assisted rather than ultrasound, unless there's some specific area I want to treat. It's faster. It's also a little bit easier to do fat injection. There are good studies, mostly done in Brazil, that documented that you can inject ultrasound-treated fat, but I still tend to use either traditional harvest or power-assisted harvest. So this is just an example of fat injection combined with implant removal with a lift. Another removal, capsulectomy, and then presents for fat injection and reaugmentation. So bottom line, all the tools and technology in the world are nothing without the heart and soul to use them wisely and mindfully. So pick and choose your tools and technique. There's lots of ways to skin a cat. I never was on the podium saying people have to use this or that it's wildly better. It's a tool. It's a great tool if you like it, but it's not for everybody. And always keep learning. And I had to, honestly, I was getting slides out and I had to look, like, did I do this with traditional lipo, power assisted or ultrasound? I didn't even know. So I think you can do any of these. You can probably get most of these results with any technique. So thank you. And are we entertaining questions?